thank you very, very much for the kind invitation to join the group again. It's wonderful to see some familiar faces, but also a whole lot of new faces as well. As Dr. Piziak suggested, my area of expertise is really in cardiovascular disease, particularly hypertension. But my charge this year, since we've heard a lot about hypertension, especially with the JNC8 guidelines, et cetera, coming out, and controversies and also congruences over the years, the charge this year was to really look at evidence-based medicine. What evidence-based medicine is, where did it come from, where is it going, how do we use it in the primary care setting, whether it be males, female disease, et cetera, in general. And I chose to actually attach it to a current controversy, so maybe perhaps the controversy would be the anchor, but the purpose of the next 20, 25 minutes really is to talk about evidence-based medicine in general. And again, how are we going to use it, apply it, in the primary care setting. Even though my area of expertise is in hypertension and my fellowship training was in hypertension and vascular disease, I'm an internist, and I'm a primary care internist, and I always will be, and always have been. I get all of my cartoons from my mother-in-law, at least when I was a little bit younger, and this is a mother-in-law induced cartoon from Texas in the Galveston-Houston corridor from the Houston Chronicle. And here is Bob and a healthcare provider, a primary care provider, trying their very, very best. And the provider saying, well, Bob, your blood pressure is extremely high. And he says, whatever, doc, I take everything with a grain of salt. And basically the slide is to remind me, not only this may have a little bit of humor, but this is the average Houstonian, but now I know that this is the average South Carolinian as well, with central obesity. And he just doesn't have hypertension. Obviously, he has premature atherosclerosis, perhaps type 2 diabetes, or he's working on it. Dyslipidemia, as the question was just asked in the past, and really is a metabolic syndrome, ticking time bomb. So even though we're going to talk about one entity around evidence-based medicine, the cartoon really does remind us all to think about the patient as a whole. And I'm sure you have none of these patients in your practices, that they're only in Columbia, South Carolina. So really, what is evidence-based medicine? What's the jargon? Where did it come from? How did it start? What happened with this beast now that we've found to be newly discovered? In the past, I think evidence-based medicine clearly was just the scientific knowledge that was accumulated around the practice of medicine or the pathophysiology of disease. However, I do think it was extremely important to coin the term and to solidify it, and not only to solidify it as a concept, but solidify it into our practice guidelines, into our education programs, et cetera, as you're going to see. Really the father of evidence-based medicine, even though it antedated Dr. Sackett, is really Dr. Sackett in his classic book on how to practice and teach evidence-based medicine. Again, now it's about 15 years ago. So this is not ancient. This is relatively new, and we're still learning about it. We're still ruminating about it, and we're still learning its positives. And also, nothing's free in life. We're also learning some of the negatives about evidence-based medicine. And let's go ahead and review some of that. And clearly, the original definition was, and we all have our own probably, is the integration of the best evidence available, but also, and I think this is kind of left out in some of our think tanks and some of our thinking, coupled with clinical expertise, and more importantly now, I think increasingly patient values, patient cultures, geographic differences, et cetera. So it was first actually described well before Dr. Sackett's classic text in the 1990s. Prior to that, it was probably clinical trials would have been the nomenclature or the brand that would have put on this body of knowledge and how it's used in medicine. In my younger days, it would have been clinical trials. It would have been population science, epidemiology, et cetera. It signaled a new approach, however. Not so much that it was new or the concept was new, but it was solidifying our thoughts. And it was also now formalizing and incorporating our evidence-based medicine thoughts into not only our day-to-day practice, but health systems management, and also, since I've been in academic medicine my entire career, in our education programs, at least in my area of control and expertise, from medical students, from UME to graduate medical education and beyond. And it started a revolution in reorienting our approach to medical practice, and I probably even could have included medical education on this slide as well when I made the slide just a couple months ago. Well, what is the approach to evidence-based medicine? First of all, it translates the need for information into a question. And this is something that was new to me. We've always developed hypotheses, etc., but now we're going to hear more and more develop questions, specific questions. Now, there's some overlap with hypothesis and the definition of hypothesis, but as you see with the new guidelines, whether they're the cholesterol guidelines or the hypertension guidelines, the committees now are asked to formulate questions first and evaluate the evidence second. And as you know, you can't answer 50 questions, so we've narrowed it down to about 3 critical questions in general that these new committees with new practice guidelines are going to entertain and ask. And that's exactly what happened with the cholesterol guidelines and the hypertension guidelines around the JNC8 committee. Then after you formulate the questions and pare them down and hone them down as specifically as you can, then you search for and determine the best evidence that's out there. But you also have to grade that evidence. You've got to critically evaluate the evidence. And then you've got to apply the evidence to the question at hand, determine where it fits, and determine actually where it falls short. And obviously then continually reevaluate. And that's why I think we need shorter durations between our practice guidelines. My God, the hypertension guidelines was a lifetime. At least it felt like a lifetime to me. And it probably was a lifetime to you. I think you're going to see shorter practice guideline recommendations, obviously around a few key sentinel questions, perhaps 3-ish, maybe not even more than that. But also I would like to really, really make a strong position to let's do it more frequently, because evidence changes. And as you're going to see with the lipid component of this anchor to anchor evidence-based medicine, it's already changed since I made these slides. Or at least there's been new data, new positions put forth. But there are limitations. Nothing's perfect in life. And I think it's probably more important for us to know the limitations of the application of evidence-based medicine than actually how to apply evidence-based medicine, of course. But more importantly, they dovetail together. Well, what are some of the limitations? And I would really strongly urge us to look at the limitations as we're taking in, obviously, the advantages of evidence-based medicine as it's applied to our practice guidelines. Well, first of all and foremost, they may conflict. They may conflict with not only the patient's values, but patient's desires, patient's culture, patient's geography, family interaction with that patient around that disease or that disease entity or that symptom. There's no question there's going to be conflicts. How do we resolve those conflicts? Because the evidence-based medicine is not drilled down to one individual or one family unit or one community or locale, if you will. It does not take into account for potential individual variation. And I think that's what I hear most strongly when I talk to my colleagues in primary care. But Dr. DePetty, I'm in that examining room with that patient that day, and my patient may be different. And the answer is yes, that patient may. And we're going to come up with the conclusion of that patient, and I'll spoil it right now. Medicine is still an art. We're applying more and more evidence-based medicine around that art, but medicine is still an art. Obviously, there's patient variation. We know that, and we're discovering the gene as the genome unfolds in front of us. We're discovering tremendous patient variation, even starting with pharmacogenetics and pharmacogenomics, patient variability to respond to drug A or drug B. And I think we're just going to increasingly find that there's more patient variation than we've ever imagined in the past. How is that going to dovetail with these large population-based practice guidelines and large clinical trials that are evaluated? These are questions to be answered. It lessens the value of clinical judgment. I hear this all the time. My role as a physician or a nurse practitioner or an obstetrician or a pharmacologist or a pharmacist is being diminished by these guidelines, et cetera. Where do I fit? Where does the individual provider fit? That's an interesting question, and we could talk about it during this week. I think that we're under some stress regarding that question. Where do we fit? All of us in this room, what's our role? And is it being lessened? I think the answer clearly is no. I think our role is going to be much more important and is increasing. However, obviously with the stresses and time constraints and productivity measures, et cetera, we feel that our role is being lessened. And it can also lead, and this is, I think, is dangerous, to therapeutic disbelief. Well, if it doesn't fit, if I don't know my role, if my patients are variable, I'm just throwing my hands up, and I'm just disbelieving everything. Obviously, that would be the last straw. None of us have ever, I don't think, approached that, right? I'm probably wrong. Okay. Well, the IOM chimes in. And again, this is really where evidence-based medicine, from Dr. Sackett's introduction to the clinical transition, has really solidified. When the IOM stepped in and said, okay, it's time for a dramatic paradigm shift. All of you have all of this information, so I'm just going to narrate some of the slides, if you will. You can try to read them, but they're also in front of you in your packets. And really the biggest paradigm shift was changing the decision-making process from based on individuals' training and experience and geographic localization to real now that the decision-making is going to be based on the best evidence. Now, that best evidence may not always be there. We're going to talk about that. But patients should receive this care based on scientific knowledge, and the care should not vary illogically from clinician to clinician or geography to geography, as we honestly know happens. Evidence-based medicine practice guidelines, then, would be essential as a new body of evidence, if you will, to sort of skip or to mend together differences in geography, demographics, et cetera, as best we can. And now we're even taking these initiatives globally. As Dr. Piziak talked about, there's going to be a huge global initiative to not only detect and manage hypertension, but to control hypertension around the world. How in the world are we going to do that? What kind of evidence are we going to use in Malawi, for instance, in Africa, or in Indonesia, or in Barbados? And that's the questions that we're asking now. Well, you've got to have some kind of definitions of the evidence as you evaluate it. The evidence is only as good as the evaluation. It's garbage is in or garbage out, or excellent in and excellent out. You have to critically evaluate, and you've got to be honest with the evidence, because there's a large contamination. If you evaluate the evidence with bias, prejudice, or just our own human nature, we've got to have some kind of dogmatic, if you will, criteria. There's been differing criteria. I've just given you a few that you all are very, very aware. From high to low, it could be 1 to 3. I've seen this in with other nomenclatures, but the gist is the same, from well-designed to maybe, kind of, splay or panorama. But more importantly, I think we're gravitating more and more to this criteria. In addition to the level of the evidence, is basically grading not only the level, but the grade of the evidence based on strong, obviously moderate, or does harm, if you will. And now you're going to see all these recommendations come out with letters. You've already seen them from the Preventive Services Task Force reports, from JNC8, from the cholesterol, lipid guidelines, et cetera, and all your societies are now grading the level of evidence from A, B, C, obviously D, which is don't do, but still the E is the biggest one. 50% or more of all of our practice guidelines to date, most of the evidence is graded as still expert opinion, which is consensus, which is the art, if you will, of medicine. Try as we may. Well, does it matter? I mean, do we have any data? What's the evidence that evidence-based medicine matters? Well, there's starting to be actually really strong evidence that evidence-based matters, and this is health systems data. This is now the larger, bigger picture. We're all now creatures of health systems, or probably going to be creatures of health systems. Dr. Martins and I were talking just about what's happening in New Jersey. Paradigm shifts are going on everywhere, including in Columbia. Even in South Carolina, where we're seeing mergers, combinations, large physician groups come together, and university medical centers and the private sector come together. Well, this is the data. If you look at quartiles of hospital quality measures based on evidence-based medicine, mortality tracks in a very, very linear fashion. There's lower mortality where evidence-based medicine as determined by quality indicators are in place, at least to a greater than 60% of the practice of that health system. It's undeniable, and this has been reproduced time and time again. So it matters. And this is a jillion patients, with 250,000 patients with over 1,000 hospital systems evaluated. But how well are we doing? Are we actually using these kind of data? And how often do we use evidence-based medicine? And the dismal fact remains almost never. This was a real wake-up call. I'm a reasonably prominent member of the American Heart Association, et cetera. And in 2008, there was a group convened to look at how often do we use evidence-based medicine, Class A or Class 1 evidence-based medicine in our practice guidelines, and it was approximately only 10%. That scared me. That surely was a wake-up call. And it was because of this data. look at all the diseases that we are treating, that we have practice guidelines, defined, definitive, expert practice guideline committees with less than 20% use of evidence-based medicine, including atrial fibrillation, which all you have to do is watch any show on television and you're going to learn all about, right on the commercials and then the newest and fanciest treatment. And this is right out of the American Heart Association and the American College of Clinical Cardiology, and you can see some very, very big diseases, some very, very high-cost diseases. At least as of 2008, we were almost always under 10% of the time, but clearly almost always under 20% of the time using level A and or class 1 evidence to guide our practice guidelines. This was a huge wake-up call for everyone. And of course, this is the publication you can find this data in. It was in JAMA 2009, and this started the revolution then to change the way practice guidelines are actually configured, who's on them, how they ask questions, and how do they evaluate the evidence. And now that's where the latest practice guideline committees have come forth with more uniformity regarding obesity, preventive cardiovascular disease. I mentioned the hypertension guidelines, and obviously the cholesterol guidelines. So even with all that, nothing's perfect, as we're going to see. So let's just take one, and as a background, try to anchor it or hook it onto a clinical entity that we see every day. And of course, there was a question just on with the last speaker regarding lipids. Let's just look at the latest and greatest 2013 the American Heart Association, American College of Cardiology cholesterol guidelines. And where is evidence-based medicine strong? Where is evidence-based medicine weak? And where are the gaps? And how are we going to fill those gaps as practitioners? Because after all, we're in the trenches. Well, we know that the practice guidelines defined 4 high-risk groups where recommendations for statin therapy only was recommended based on 2 intensities, moderate intensity dosage statins and high intensity dosage statins. For the anchoring of the evidence-based medicine component, I only want to look at the last group, the 4th group. The first 3, I think all of us probably, just with the art of medicine, would probably come down on the side as we reviewed the evidence, and the evidence is strong. We're probably reasonable consensus that you should start statin therapy on patients with known cardiovascular disease, extraordinarily high LDLs, probably the familial heterozygotes for FH and LDH receptor disease, the mixed combined hyperlipidemias, and of course in diabetics as well, as Dr. Piziak has taught us for years at this conference, including now I learned osteoporosis. I am trainable, Dr. Piziak. But let's turn to the last one, and that's really where the evidence-based medicine became weaker and the controversies became stronger. However, there's going to be good news at the end of this. And this was the recommendation. Primary prevention in individuals that are not diabetic, don't have cardiovascular disease that's known, and does not have extraordinarily high elevated levels of LDL cholesterol. So primary prevention. When do you initiate statin therapy, if at all? And of course, the recommendations were, yes, you do. You do if you use this fancy risk calculator. I just learned a little bit about the FRAX risk calculator this morning. Well, this would be the FRAX for lipids. And was it an old risk calculator? Did they use the Framingham Heart Risk Calculator, et cetera? And the answer is no. The committee actually reviewed newer data, or the newest and greatest data, and developed their own risk calculator. So it's a new risk calculator. And you all have it on your iPhones, I'm sure, already, and you've already used it. And the recommendations were for primary prevention, for lower levels of LDL, irrespective of the LDL level, although the cholesterol and the HDL is in the calculation, that if you have a greater than 7.5, 10-year cardiovascular risk, you start high-intensity statin. And if you're in between 5 and 7.5, you start moderate intensity statin. And any of those on the white side, that's the art of medicine. Less than 40, greater than 75, there's just no data. There is no evidence that could be reviewed. And of course, if your risk is less than 5%, well, what are you preventing? Your risk may be just too low for the risk of the drug to exceed potential harm. And the benefit exceed the harm. But really, the two on your left was the highlight, based on the risk calculator. We're putting a lot of our faith then in this risk calculator. So that's really the key. Well, how good is it? And why is it new and improved? I actually think it is new and improved. It was new and improved because the group took a second shot at it and was more inclusive. It did represent more diversity of our patient pool, particularly African Americans. For the first time, there was a significant and new data that included some different demographics, some more diversity, geographic diversity, et cetera, and white, black men and women were now included in the risk calculator. That's going to change a lot of things if the diseases, prevalences, and target organ damages differ amongst demographics, races, ethnicities, et cetera. It more accurately defined the high-risk individuals for statin therapy. I have not seen yet any argument that it doesn't do that it doesn't do really, really well with the high-risk individuals. And we're going to play with this calculator a little bit on one slide. It was my rudimentary attempt to play. But it may be overestimating the criticism that's come from the lower end. It could possibly be overestimating the lower risk. And what would that mean? That would mean we would be placing more and more people on statin therapy. And is that what we want to do or not? That's what the risk calculator says we should do if we just go along the risk calculator. And that's where the controversy came. And this is the risk calculator. You can just go right on. Again, you've almost all, I have to assume all of us have this. I've got it on my iPhone. I've had my medical students loaded on their iPhones. I've had my residents all loaded on our iPhones or our smartphones, et cetera. So it's just a little finger away, just like that Frax. Well, let's just take some of the low-risk individuals and see how the risk calculator now changes things. Particularly now, we're talking primary prevention. I made some scenarios up. On the far left, I just made one. Let's start somewhere. Let's start with a guy, a male, although this is female, so we're going to end with female, our female patient conference. 60-ish years old. That's really, really young. Because as Dr. Piziak said, my definition of elderly is 1 day longer for every day I live. But white, let's just take the white race first. Total cholesterol 200, HDL of 70. Notice there's no LDL on the risk calculator. So a systolic blood pressure, let's make it pre-hypertensive because at 60 years old, probably most of us are going to be pre-hypertensive as we age. Our systolic blood pressures are already starting to rise. But clearly, no, not defined hypertension, not treatable hypertension yet by any guideline, et cetera. But no obvious hypertension, not on therapy, and never was diagnosed with hypertension. No diabetes, no smoking. Relatively okay 60-odd-year-old with reasonable numbers. And if you plug all those numbers into the risk calculator, my goodness gracious, what do you get? 11.4%. I was stunned when I did that. I was running my prescription pad, right? I was going to actually run to my doctor. Should I take statins? But that the risk calculator would say yes. And not only statins, but high-intensity statins. Well, let's change it. Let's make the individual now just 5 years older. Still very, very young by any definition from Don to Petty. It now jumps up all the way to 16%. Let's now just only change one other thing. Let's change the race. 60-year-old black, it actually goes down. And that's why this is so variable, and I'd encourage all of you to plug in some hypothetical individuals. But let's turn our attention now to females, which may be a group that if particularly vulnerable to overestimating risk, it would be our female population. And again, but if it's a female now, and the only thing I changed was female, the risk drops down to 4.7%. Under 5%, and you would not treat this individual. So you can see only thing I changed from the first scenario was made the patient female. Huge difference in cardiovascular risk just based on gender. Maybe good, maybe a good thing. But if you make that female now 65%, therapy, right? Moderate, or you might even be swayed to use a high-intensity statin because you're approaching 7.5% 10-year cardiovascular risk. And if you put race on top of this female patient now, you're always treating this patient, whether you're 60 years old or 65 years old. That was astounding to me when I actually saw the data and I plugged in the data. It's one thing to read the guidelines and go, all right, but then when you start putting in some of these numbers, it's like a wake-up call. That's my entire practice. I was going to ask Dr. Piziak, and I'm still going to ask Dr. Piziak, Dr. Martins, my question about vitamin D. because our primary care clinic in South Carolina is heavily African American. It's heavily female, and it's heavily postmenopausal females. So I do have a question I'm going to ask sooner or later about vitamin D in African American postmenopausal females, because we see all low levels. It's 100% low. And I don't know what to do with those individuals because, as we know, I'm pontificating now, it's a mess because of binding protein to vitamin D. But you can see now that race matters, age, even small changes makes huge differences in the calculated risk and will make huge difference in terms of initiating statin therapy, irregardless of the intensity, whether it's moderate or high-dose intensity statin therapy. Well, there's been evidence. Well, where did this evidence even come from? It came from these 3 trials, so we're going to go very quickly. The Jupiter trial, these are all primary prevention trials. They showed that primary treatment with statin therapy decreases risk, cardiovascular risk, almost by 50%. That's good. So they plugged in this kind of data. Well, there's more. We could try the Texas Air Force study. Same thing, primary prevention, statin-based therapy. Again, LDL levels that were, at that present time, would not have been treated. And again, 37% risk reduction. And you can take these patients and you can plug them into that calculator, which they did. So now we're getting thousands and thousands of patients, but not hundreds of thousands or millions. And lastly, and most recent, was the mega trial from Japan. Same theme. And you have all this data in your packets if you want to review it. Again, primary statin therapy for primary prevention versus placebo. Same results. Highly significant reduction in cardiovascular mortality. And you can plug these numbers into the risk calculator, and that's what they did. These were the 3 trials that they reviewed and they utilized, and they weighed heavily. So based on that, those 3 trials, this is what you come up with. 5% is the initial cutoff for statin therapy for benefit, based on evidence-based medicine. And of course, as you can see, 7.5 for 10 years. That's where it comes from. Evidence. You may not like the evidence. You may change the evidence. You may want to throw out the evidence, but it's evidence-based. And the need to do good versus harm, the cutoff for moderate and high intensity was 7.5% to 10. Totally in line with the guidelines. And again, even with moderate intensity, it was 5.7. Totally in line with the guidelines. They just didn't make these up, sitting around 2 martinis in the middle of the night. Or in the morning, as I learned about Scotch and the British Open. But there's been pushback. First of all, we know that if you're greater than 75, there's no evidence. If you're on hemodialysis, don't do it. It's harmful versus benefit. And if you have heart failure, conclusive. And the major pushback came from this, though, the overestimation of the risk. You can look at this in your own leisure time, but if you use any of the large studies in the past, based on the previous, like say ATP3 guidelines, et cetera, you can now show that we will extraordinarily expand the number of individuals that are treated with statin therapy with the new guidelines. It's not even close. As you can see, it's going to be maybe 10, 20, 30, 40% more individuals on statin therapy based on the new calculator. And that led to a whole lot of papers. 12 million, 13 million people potentially now will be eligible for statin therapy. Primary prevention, almost all of it will be for primary prevention, as opposed to those other 3 groups, because we've already been basically treating them. They were not that controversial. And it's going to be in older, at least Americans. And this is the numbers. 40% in the moderate risk, if we, in terms of adults, 40 to 60. It'll be 87%, 60 to 75. Might as well give it to everybody. Huh? That's what Dr. Piziak asked me, am I on a statin? No. And again, you can just, women, this is obviously a female-centered conference. 73% will be on at least moderate intensity statins if you're just a female in these age groups, and men to 95%. All men greater than 60. That's why I picked that 60 in that risk calculator examples for you. Essentially all males greater than 60. Forget the calculator, just based on what we know about the demographics of males. That may not be a bad thing. That's just that's what the data is showing. So that's where the criticism came back and the pushback came back, is perhaps we're overestimating the use of statins in the low-risk group, these 5%-ish to 7.5% or maybe even 10%. And that's where we stood until about a month ago. And then there was 2 major publications, one in JAMA, that actually started doing cost analysis of quality of life years saved and actually reinforced in a positive manner using the present risk calculator. That if we do all of this good stuff and we treat all of these individuals, that we're going to save a significant number of lives, morbid and mortal events in these age ranges, including up to 75 years of age, and it's cost effective because I believe, Ronnie, the quality of life adjusted analysis was around $30,000 a year, which people would find, all of us would find acceptable in terms of a cost-benefit analysis. That's usually a very favorable cost-benefit analysis for benefit versus harm versus societal and public health costs. So let's conclude. What have we learned? We learned that, first of all, what I've learned is evidence-based medicine is here to stay. I still think we have to question when we use it, how we use it, and why we use it. Number 2, we must understand its limitations, more importantly, actually, than its advantages. We need to know when not to use it and when to use expert opinion, because even like today, our practice guidelines are 50% or greater based on expert opinion, E versus A, B, or B. Also, remember, the lack of evidence doesn't mean lack of efficacy. It just means we don't know. And that's where the art of medicine is going to come in. I think whether we like it or not, or whether one wants to hear it or not, or if a government agency wants to hear it or not, tough. Medicine, health professions, no matter what our walks of life are, no matter what our specialty, or no matter what locale or community we're coming from, medicine, and I'm glad that medicine and healthcare is still at least significantly an art, and that's our role. Our role is to mix art and science together and come up with what's best for our patients when we're in that examining room alone, individually with them and their loved ones. That's the final common pathway, and that's what matters. That's our role. Let's not shirk from it. And thank you very, very much for having us. Ronnie, I know we ran late. So.
Okay.
By the way, this is what? No, this is the first time we tortured a medical student. This is the first EKG. So we've come a long way. I was like to be the medical student that's told, just sit here with all these wires, and we're going to plug all these things. And by the way, put your hands in these buckets, and I'm going to pull the switch. I would love to do that just once. No, that's our first EKG. We've come a long way, as you can see. Luckily, the electricity was outgoing instead of incoming, but I'm not so sure I would have trusted that. Questions, thoughts? Yes, talk to me. Let's talk.
I found those 2 guidelines very confusing. So you've got a high-risk person, your algorithm says put them on high-intensity statin therapy.
Right.
You're not treating to a goal number.
Right.
At the bottom of the algorithm says monitor statin therapy.
Yep.
What are we monitoring statin therapy?
I can answer that for you, but I think now that there's even a newer study that's going to help us with that question that the committee, that was not available to the committee. The reason they put that in was, I think, number 1, it was a fudge factor, because I think they were not ready to divorce us entirely from measuring the lipids after we start initial statin therapy, because it was not, other than that one group, it's not based on your LDL level, right, unless you're 190 or greater. They used the escape route, which I think was appropriate for compliance, because you had to determine whether your moderate intensity statin was working. And remember, that was defined as a greater than 30% reduction in your baseline LDL. And a high intensity would reduce it more than 50%. So it was based on the recommendation to continue to monitor LDL, et cetera, HDL, lipid profiles before and after you initiate the therapy was based on compliance. Is the patient taking the medication? And is it being effective? Are you reaching the effective targets that the evidence-based medicine reached that was then leading to the recommendations? However, having said that, there's a new study. And of course, we're all aware of the study in the New England Journal of Medicine that just combined statins with obviously a a sequestrant and showed that even lowering the target LDL to under 70 down to 50 and 40 further decreased coronary artery and coronary-related event rates. And that was not available to be reviewed by the committee. So I still think now there's even stronger evidence to continue to monitor lipids and continue to monitor goals, if you will, in addition to what's recommended in the moderate to high intensity statin. Does that help you? Yes.
While we're on the intensity of the statins, where are we treating to goals, such as how low are we going in our diabetic patients
Right.
and in our cardiovascular patients? Because before it was less than 70,
Right.
the lower the better.
Right.
And there was a new study, I was reading study in the Improvement trial.
Yeah, that's exactly it.
Yeah.
But that's
And there was some evidence where the lower it is, the better.
better. Yep.
Especially in our cardiovascular patients. So where are we going with
Right.
this guideline, and that's evidence-based, so where are we going?
Right, and that's why I'm strongly advocating to making the guidelines shorter, more focused, but reviewing them more often, maybe even yearly, maybe even shorter than that. Based on the guidelines that are out there now, the 2013 guidelines, the only goal was to reduce it 30% or greater if you were in the moderate group. That was the goal because that's what the evidence-based studies did. They did reach that goal of less than 30% with the pravastatins of the world, if you will. And the high-intensity statins, the goal was to reduce the LDL by 50%, and that was based on the evidence. It was a percentage goal, not a target goal. But those were the goals that were achieved in those three trials that we looked at, whether it was moderate intensity statins or high-intensity statins. The new data, though, and one study should not have probably changed our clinical practice, but the new data is the recent study in the New England Journal of Medicine, which did show that even achieving the 50% or greater goal on the high-intensity statin, adding that second drug, and I don't think it has anything to do with the second drug, it just had to do with driving the LDL lower. That's the first study that has shown that treating to a lower goal had further cardiovascular benefit. I think now we're in that phase now where we're really in the art of medicine now. Where do we as practitioners now take that study, that we review it, et cetera, and chew on it, and then how do we put that study in clinical practice with our patients today based on the 2013 guidelines? I think clearly you would say if you had a high-risk cardiovascular patient, you probably would drive the LDL lower, but now that's based on one study, and that's that discussion in that exam room between you and the patient and their loved ones. Joan.
Over 75.
Well,
I've got a 92-year-old who's a cardiologist insists that she stay on her high-dose statin.
but she's doing well. If it ain't broke, don't fix it. Well, there's no evidence. I mean, that's where you're totally, you're working on expert opinion, and you're working on the art of medicine. First of all, congratulate that 92-year-old, because I want to be that 90. Can I come into practice? You'll guarantee me that? Don't know. And but remember, lack of evidence doesn't imply lack of efficacy. It doesn't mean it's not beneficial. It just means we don't have any evidence to evaluate that age range. Just like in the hypertension guidelines, if you really read them carefully, we don't have any evidence to treat young people with antihypertensive medications, even when they have hypertension, because the evidence, the studies, had age cutoffs, 30, 40, et cetera. So, and you'll see it prominently that for younger individuals with hypertension, Joan, it's expert opinion whether you should treat them or not. Now, what's young? 35, 38, 40 years old. Yeah.
I think that's where people get frustrated with that calculator.
Yes. Mm-hmm. Right, absolutely. I just don't want frustration to turn into nihilism or therapeutic inertia or not to think. I think, though, that because lack of evidence doesn't imply lack of efficacy, that's our role. That's our world in that examining room to take the data, discuss it with the patient, discuss it with the family, discuss it with your subspecialists, with your cardiologists, your endocrinologists, if it's obviously a female patient with our OBGYN colleagues, and come up with the best possible solution, taking into account, though, the patient's values, the patient's wishes, et cetera. I know it's a long-winded answer to, like, what is it called? It was a long run for a very short slide.
All right, I'll start at 10 so we can get out on time.
Oh, I am so sorry.
I'll start at